Hello everyone, this is Dr. Manpreet Khurana, and today we'll be discussing the exam assessment of fundamental knowledge, which is the first step for Canadian board exam preparation to become a licensed dentist in Canada. The assessment of fundamental knowledge, AFK, we'll be discussing that what is the blueprint, that what all questions are focused upon, what kind of questions are asked in the exam, and we'll also discuss questions for this particular exam. Now, when we talk about the questions, there are a lot of important topics which are asked in this particular exam. So we'll be discussing all the important topics. I'll be teaching all those topics step by step. We'll be taking in some questions which are important, and there'll be a series of lectures. So this is part one. I have made a series of videos, so you can watch the videos one by one so that you know what all topics are there and you know about the topics in detail. So let's start. So the first and the foremost is the blueprint. So let me just explain this to you, that what is this blueprint all about. Now, previously, if you see the previous blueprint, which is given by NDEB, there are slight modifications. The first and the foremost modification is they have changed the basic sciences and they have changed them to applied aspect mainly. So now, previously, there used to be some questions based on the very basic core concepts of biochemistry, anatomy. But now what they're doing is they're mainly focusing on the applied biomedical sciences. So in the applied biomedical sciences, which is anatomy, biochemistry, biomaterials, cardiology. So if you see in the basic sciences, they have also included, these dental related subjects, cardiology, growth and development, histology, immunology, microbiology. If we talk about microbiology, the questions which are mainly asked are related to periodontal microbiology. Nowadays, we are not seeing a lot of questions from the core microbiology. Then there is oral embryology and physiology related to the dental field. Um, so the core questions are very rare, but to be honest, we have to understand these core concepts as well, because when we talk about any correlation with the dental problems or the dental pathologies, we have to understand that what is the core concept, what are the core concepts, because otherwise we won't be able to understand that. So basic sciences are definitely important, but now they are more of the applied aspect. So we'll be during the course of our lectures, which I'll be taking, we'll be discussing more about the applied basic sciences rather than going to the core concepts of basic sciences. So the percentage of questions which are asked are 20% plus minus 5%. So you can say roughly 25% to the max. But definitely they're not purely basic. They are applied and related to dental periodontology, like dental microbiology related to periodontics. Then we have oral embryology, we have physiology, immunology, and oral histology, right? So these are related subjects. Then we have the prosto, restorative, and implants, which is around 16% questions. Oral medicine, oral pathology, and oral radiology. So if we talk about oral pathology, definitely oral pathology is very, very important. And there are a lot of questions asked, and it is a very vast subject. Pharmacology, they have, related pharmacology mainly to the dental sciences, but definitely there are many drugs where as a dentist, we need to know that if there is a, drug which is given for any other medical disease or medical ailment, we have to understand that what is the correlation with the dental outcome, right? So we have to understand pharmacology in detail. We'll be reading that in detail. Orthodontics, definitely. So ortho, pedo, geriatric, and special needs patient, 8% questions. Then periodontics, 8% questions. Oral surgery, trauma or official pain, and dental emergencies. So 8% questions. Endodontics, 6% questions. And last but not the least, EBD, that is evidence-based dentistry, ethics, infection control, and other related topics. So basically some very rare, some questions related to dental public health. There is another exam which is known as ADAT. The basic difference now, AFK is only for Canadian dental boards, but ADAT is a common exam if you want to go to the university. So if you take the university route, then the exam is ADAT. The only difference between AFK and ADAT is, I would say there are few differences, but the main difference is based on the public health, dental public health. So there are some questions, public health, some questions related to public health stats and other related fields, and some applied aspects and questions related to judgment are also asked in ADAT. So ADAT is a slight different exam. So you can say it's a slight combination of AFK and the second exam, which is ACJ. But all in all, the core concepts are same. They'll be taking care of all these things, and the core is same. So if you do AFK, you are also preparing yourself for ADAT. Okay, let me just go to the next slide. Okay, now let's go to the questions. Let's start with the question number one. Um, there'll be around 2000 questions which we'll be discussing in detail over a series of lectures. There'll be a lot of lectures. Now, the most important thing whenever we talk about any question, like for example, lichen planus occurs most frequently on which surface? Buccal mucosa, tongue, floor of the mouth, and gingiva. In this, obviously, if the question is asked on lichen planus, this is a very important topic. So we'll take most important points related to lichen planus. We'll explain them. I will let you know what other questions can be asked related to this topic. So let's talk about lichen planus. This is a picture of lichen planus. This is a uh, classic presentation. So let me just remove this so that you can see. Now, this on the left side, this image depicts a classic presentation of lichen planus featuring polygon-shaped, itchy, violaceous, flat-topped papules. So if you see, these are the flat-topped violaceous papules. We'll discuss what is a macule, what is papule in detail. The lesion illustrates the 6 P's of lichen planus. So whenever we talk about lichen planus, there are 6 P's. So 6 P's. So the first P is they are purple. When we talk about the skin, they are polygonal, they are pruritic, they are planar, papules and plaques. Papules and plaques. If we talk about the oral counterpart of lichen planus, so this is on the skin and this is the oral counterpart. The oral lichen planus, if you see, it is showing reticular subtype. So there are different types of lichen planus which we'll discuss. So this is a reticular subtype. It is depicted as asymptomatic white lacy lines on the buccal mucosa. So this particular is the buccal mucosa area, and if you see, they are the lacy lines. So even in the explanatory diagrams, it is shown on the buccal mucosa. So the answer is buccal mucosa. We'll discuss how. Now, lichen planus is an inflammatory condition, okay, of the unknown etiology. Now, the etiology is still unknown, affecting the skin and mucous membrane. So it is affecting the skin and the mucous membranes. This condition typically presents as itchy, violaceous papules and plaques. So there can be papules and there can be plaques, commonly located on the wrist, lower backs, and ankles. If we talk about the general body, a distinct lattice of white lesions, lines known as Wickham striae, often overlays the lesions, and it's often easily visible on the buccal mucosa where erosions may also occur. So you can commonly find it on the buccal mucosa, and Wickham striae is very important to learn. Drug-induced lichen planus or lichenoid drug eruption. So there is a similar pathology which is drug-induced. It can resemble idiopathic lichen planus, often displaying a photo-distributed pattern, making differentiation between the two forms challenging. So sometimes if we have to differentiate between the two forms, it becomes challenging thing for us. Now let's understand the histopathology of lichen planus. So if you talk about the histopathology of lichen planus, so lichen planus can affect various areas of the oral cavity. Studies consistently show that buccal mucosa is the most common site. So which is our question, that buccal mucosa is the most common site of involvement. Very important. Now, the skin biopsy and microscopic analysis are valuable in confirming the diagnosis in atypical and severe cases, as the histopathological features are generally the same regardless of the distribution or subtype. Principal findings. Well, what are the principal findings? They are thickening of the stratum corneum without nuclei. So whenever the stratum corneum, so if you see on the left side in this diagram, there is thickened stratum corneum. So the topmost layer is the stratum corneum. It is thickened. It is parakeratinized. So what is sorry, it is without parakeratosis. So if you see hyperkeratosis without parakeratosis, so we'll understand what is parakeratosis, what is orthokeratosis, and when the nuclei is present, when the nuclei is absent, what happens. So we'll discuss. So irregular thickening of the stratum granulosum. So if you see, this is the granular layer, second layer. So there is irregular thickening, destruction of stratum basale. So if you see that there is sawtoothing of the dermoepithelial interface. So if you see, there is a sawtooth-like structure here. Alteration of the loss of the retipex resulting in a sawtooth appearance. So if you see, there is a sawtooth appearance and a dense band of lymphocytes infiltrating the dermis along the dermoepithelial junction, or we can also call it interface dermatitis. In addition, idiopathic lichen planus really demonstrates, so eosinophils are rarely present, whereas drug-induced may show eosinophils. So always remember, this can be one of the differentiating features. So in the case of idiopathic lichen planus, the eosinophils are rarely demonstrated, whereas in drug-induced lichen planus, the eosinophils are there. Right. So this is the general overview. What is stratum corneum? Layers of the epidermis, dermis, and hypodermis. In the epidermis, we have stratum corneum, stratum lucidum, granulosum, spinosum, and basal. Okay. So these are the layers of the epidermis. Now there is apoptotic keratinocytes are often observed near the basal layer and are termed colloids. So sometimes we see the colloid or the civet bodies. Direct immunofluorescence staining may display colloid bodies with irregular deposits of immunoglobulin, which is IgA, IgM, IgG, or C3. We'll be taking a small lecture on immunoglobulins. The isomorphic response known as the Kobner's phenomena. So these are some of the questions which can be asked. It can occur in lichen planus wherein new lesions arise in the lines where scratching occurs, similar to what is observed in psoriasis, which is another skin disease. Mucosal involvements affect over half of all the patients with lichen planus and frequently is the sole presenting sign. So sometimes the mucosal involvement is the only presenting sign. Most commonly observed in the mouth, okay, but it can also be found in the lips, esophagus, glans penis, vulva, or vagina. 6 subtypes have been found, which can be reticular, erosive, papular, plaque-like, atrophic, and bullous. Reticular is the most common form and presents, which we have seen in the picture. It presents as asymptomatic white lacy lines on the bilateral buccal mucosa. So that is the reason that lichen planus is most commonly found on the buccal mucosa. The erosive and the atrophic forms are commonly associated with burning pain exacerbated by the hot or the spicy foods. Lesions can easily be mistaken for leukoplakia or candidiasis on the tongue or buccal mucosa. So you can say we can involve them in the differential diagnosis. Esophageal lichen planus predominantly affects women and can give rise to dysphagia, strictures, and possibly squamous cell carcinoma. So there can be esophageal lichen planus. Predominantly, it is affecting the women. Question number 2. So if we talk about question number 2, it is asking what is the most likely diagnosis of a white lesion on the retromolar pad opposing a non-functional molar. Now, whenever we have to discuss or whenever we have questions, when they're talking about a particular area, always remember that oral pathology is slight confusing. There are a lot of overlapping symptoms and signs, but whenever we talk about the particular area, like in this case, the retromolar pad opposing a non-functional molar, and it is a white lesion, then we have to remember that why this particular option is correct and other options are not correct. Sometimes we can solve the question based on exclusion, right? So let's first see or understand about this particular all 4 options, and then we'll come back to the question and we'll see how we can solve it. In this, you can see on the left hand side, there are 3 pictures and we are talking about bark. So benign alveolar ridge keratosis. It is an intraoral counterpart of cutaneous lichen simplex chronicus. Okay, it is an oral counterpart. It is a reactive hyperkeratosis caused by trauma or friction that presents as a poorly demarcated white papule or plaque on the keratinized mucosa of the retromolar pad or alveolar ridge mucosa. So most of the times, if you see alveolar ridge mucosa, it will be present in edentulous patients or the retromolar pad. So in this picture, if you see, this is the area of the retromolar pad, right? And here also, we are talking about the retromolar pad. So there is keratosis on the thick alveolar crest ridge. So this is the alveolar ridge, and there is keratosis on this alveolar ridge crest. Okay, it is like edentulous from here. So when we talk about the benign alveolar ridge keratosis, we usually see the white plaque or papules on the keratinized mucosa. So this is the retromolar pad area, and you see the white plaques or papules. Okay, let's go to the next. Now, bark showed hyperkeratosis, often with wedge-shaped hypergranulosis and occasional focal parakeratosis. If we talk about parakeratosis and orthokeratosis, let's first understand what are these two terms because we are getting them again and again. Now, ortho and parakeratosis are two types of hyperkeratosis. So whenever there is increase in the number of cells of the keratinocytes, it can be of two types. It can be orthokeratosis or parakeratosis. Now, in this case, the stratum corneum, which is the outer layer of the skin, it thickens. Now, the key difference lies in the presence or absence of nuclei. Orthokeratosis is normal type. It has a nucleus. So what happens is when the keratinocytes mature, when they go to the stratum corneum outside layer, they lose their nuclei. Normally, they lose their nuclei. Now, orthokeratosis is thickening, but it is a normal type of keratosis, whereas no nuclei are present. But if you see nuclei present here, right, then it is known as parakeratosis. It is known as parakeratosis. So I would say abnormal one is parakeratosis, which has nuclei in the cornified layer. So again, parakeratosis is abnormal one and orthokeratosis is the normal thickening of the stratum corneum. Now the epithelium exhibited acanthosis. Now what is acanthosis? Is increased thickness of stratum spinosum. Okay, so when the stratum spinosum, there is increased thickness or hyperplasia, that is increase in the number of cells, then we call it acanthosis. And surface corrugation with tapered rete ridges often interconnected at the tips. Now this is a particular study. We're not going into the details of the study, but here we have to understand that there is acanthosis or there can be orthokeratosis, hypergranulosis. Acanthosis is irregular hyperplasia of the stratum spinosum. So this is the stratum spinosum. It can occur in psoriasis, chronic spongiortic dermatitis, lichen simplex chronicus, acanthosis nigricans, bacterial and fungal infections, and syphilis. Orthokeratosis is thickened stratum corneum that is devoid of nuclei. So in this case, there is no nuclei. So it can be lichen simplex chronicus and lichen planus. Then we have hypergranulosis, which is a granular layer thickening. It occurs in lichen simplex chronicus. So all the three are occurring in lichen simplex chronicus, which is whose oral counterpart is bark. Then lichen planus, verruca vulgaris, and bovinoid papulosis. Now, this is a question where he's asking that which condition has not been associated with Candida albicans. So it means that one of them is not associated with Candida albicans infection, right? So let's see that what all these options are. One of them is median rhomboid glossitis, angular cheilitis, denture stomatitis, aphthous ulcerations, and oral hairy leukoplakia. I know many of you would already be knowing these questions. They are very popular questions. They're given everywhere. They have come many times in various exams, especially like the NEET exam as well. They're coming. So these questions are important and these topics are important. So we have to discuss these topics and questions in detail. Now, here we'll be talking about the oral candidiasis. Now, oral candidiasis is commonly referred as thrush. It is an opportunistic fungal infection that commonly affects the oral mucosa. The main causative agent is Candida albicans. It is highly versatile commensal organism that is well adapted to its human host. However, changes in the host microenvironment can promote the transition from one commensalism to a pathogen. So it is a normal Candida is normally present in our body, not causing any kind of pathology. But if there is immunosuppression or other conditions, which is happening in the body, then the Candida can become pathogenic. Now, these are the various oral manifestations of candidiasis. In the first picture, if you see, this is a oropharyngeal candidiasis. It is characterized by diffuse thick curdy white plaques, and they can be wiped off. So sometimes this question is also asked in the exam. Okay, they can be wiped off with gentle scraping with extension from the soft palate, which is oral candidiasis, to the oropharynx. So it is going towards the pharynx. So this is a type of oropharyngeal candidiasis. In the picture number 2, we have acute pseudomembranous candidiasis. It is in a HIV patient. So this is a case of HIV patient where there is immunosuppression. Multiple coalescing raised white plaques on the hard palate. So if you see this area, right? Hard palatal mucosa on a background of underlying diffuse erythema and hyperplasia. So there is diffuse erythema and hyperplasia, right? So this is known as acute pseudomembranous candidiasis. Candidiasis. Now, in the picture number 3, we have the third one. So third one is Newton's class 2 denture stomatitis, clinically manifesting as diffuse erythema. So whenever we talk about the denture stomatitis, it is characterized as a diffuse erythema on the mid-palatal mucosa in a partial denture wearer. Then in the fourth picture, we have a case of angular cheilitis. It is presenting, which is one of the options in the question. So it is presenting as a bilateral erythema, right? Erythema and ulceration, right? So bilateral erythema and maceration of the angles of the mouth. Clinical images of consented patients. So these are the clinical images of patients which gave their consent. So they are the original pictures. Now, as a primary reservoir for oral Candida carriage, the tongue dorsum is the initiating point. So if you see the tongue dorsum, sorry, here is the initiating point of infection for the majority of the clinical forms of oral candidiasis. This includes oropharyngeal candidiasis, characterized by invasion of the epithelial cell lining of the oropharynx, which often occurs as an extension of oral candidiasis. There are multiple clinical presentations and several classification systems for oral candidiasis. However, the most simplistic classification encompasses oral manifestations that can generally be classified into three main broad categories. We have the acute manifestations, chronic manifestations, and chronic mucocutaneous candidiasis syndromes. It is important to note that several clinical forms can occur in the oral cavity and in multiple oral sites at one time. So additionally, although other non-Candida albicans Candida species can cause the oral candidiasis, the manifestations are identical irrespective of the causative species. Okay. Now, angular cheilitis. There was one of the option as angular cheilitis. It's a term implies affects the angles or commissures of the mouth, and it presents with erythema and maceration, fissuring, crusting, or a combination thereof, right? Now the presentation can be unilateral, but it is more often bilateral. So we have already seen, and they are also commonly associated with Candida. So we can say that the Candida is associated with angular cheilitis. Now the next option, which was median rhomboid glossitis, right? So this is a picture of median rhomboid glossitis. It is also refers to as atrophic glossitis or central papillary atrophy. It is present as a central elliptical or rhomboid area of atrophy and erythema of the midline, posterior tongue dorsum, anterior to the circumvallate papilla. This lesion was historically attributed to the developmental origin. However, this is unlikely as pediatric cases are seldom encountered. This condition is often associated with frequent use of steroid inhalers or tobacco smoking. So we can say that in these cases also the Candida albicans infection is concurrently there. Then the next one is aphthous ulcerations or canker sore. It can be a secondary complication, the thrush. So oral candidiasis can occur as a secondary complication. Now, the only option left is oral hairy leukoplakia. It is a condition which is causing white textured patches on the tongue, most commonly on the sides. It is caused by Epstein-Barr virus. So oral hairy leukoplakia is associated with Epstein-Barr virus and is often seen in people with weakened immune systems, particularly those with HIV. The white patches have corrugated or hairy appearance, hence the name. Now, it is considered as a benign lesion and doesn't usually require specific treatment. Okay, so let's see. So we can say that the median rhomboid glossitis, angular cheilitis, denture stomatitis, and aphthous ulcerations are usually associated with Candida albicans, but oral hairy leukoplakia is a viral disease which is not usually associated with Candida albicans. Now we go to the question number 4. So the question number 4 is about the occlusal rest, which is a line which is drawn through the occlusal rest of two principal abutments. So whenever we talk about removable partial denture, we have the abutments, which are the principal abutments on which the removable partial denture is retained, right? So it takes support retention from there. So if we talk about these lines, they are called as the fulcrum lines. So if you see on the below pictures, there are three pictures. This fulcrum line is an imaginary line. If you see here, in this case, in this case, and in this case, right? So in the first case, this fulcrum line is passing through the area of the occlusal rests, right, of the abutment. So this is the denture, partial denture, right? And these are the abutments, right? So it is taking support. So if you see, there is occlusal rest here as well here. So there is an imaginary line on which this partial denture is kind of rotating, right, on this axis. So these are known as the fulcrum lines, right? So you'll be reading about these fulcrum lines in detail. So there are different types of fulcrum lines. So the fulcrum line on class 1 partial denture. So you have to learn the classification of class 1, class 2, class 3, class 4 and modification areas, or we call them mod areas. So we have to learn the classifications in detail. In the picture number A, we have a class 1 partial denture. So if you see, it is all the posterior part is edentulous on both the sides, bilaterally edentulous area posteriorly. So the fulcrum line is passing through the occlusal rest of the most posterior abutment on either side, right? Here also, it is passing through the most posterior abutment on either side. So these are the various fulcrum lines. So these are A, B. So C is the fulcrum line. D, we have E, which is passing through the anterior ones. So if you see, if we talk about this one, this is a class 4 partial denture. The fulcrum line passes through the two abutments adjacent to the single edentulous space, which are E and F, right? So this is a single there is a single edentulous space. Here also it is a single edentulous space. So in these, the length of the edentulous space doesn't matter. It is considered as a single edentulous space, and the most posterior edentulous space governs the classification. There are various rules, Kennedy's classification and other rules, which you'll be learning in prosthodontics. Here we have to just understand what are the fulcrum lines on which the denture can rotate. Okay. Next question is the immunoglobulin question. Now, this is a question based on immunology. Now, if you see, they're asking a question on immunology, but they are relating it to the, saliva. So the simple that we have to understand the immunoglobulins in detail, and we have to understand where it is predominantly found, which area, and what kind of immunoglobulins are there. So isolated from the saliva. So if you talk about saliva, it's always IgA, but we'll read about all other immunoglobulins in detail. This is a wonderful chart wherein all the immunoglobulins and their important concepts are given. We'll read them and we'll try to remember some of them in detail, that what all basic immunoglobulins are there and what is their role, right? Where they're found, what all types of hemoglobins are there. Okay. So the first one is IgG. Uh, it's always based on the heavy chain. So there are two chains, heavy chain and light chain. So on the right side, I have attached a small picture so that you have a brief idea that this is the light chain and this is the heavy chain. So this one is the light chain. This is the heavy chain, the inner ones. So we have different regions. One is known as the variable region and other is known as the constant region. Here we have the antigen binding site. So there is an antigen immunoglobulin complex which is formed, antigen antibody reaction. So this is the site where the antigen binds to the antibody on both sides. So this area is known as the variable region. Now, IgG. IgG, so we have five types of immunoglobulins mainly: IgG, IgM, IgA, IgE, and IgD, right? Based on the heavy chain, right? So we have GAMDE. Usually we can make a mnemonic like GAMDE, right? So the first one is G, right? The G is half-life is 23 days, and most like you can say 80% of the immunoglobulins are IgG, right? That is why we learn them as GAMDE, right? Gamde. So G is the most prevalent. It is a major serum immunoglobulin. It is a normal serum concentration is 8 to 16. Okay, only maternal immunoglobulin that cross the placenta. So this is the only immunoglobulin which can cross the placenta and provides natural passive immunity in the newborns. It is a classic complement fixation. We'll read about the complement system, right? Classic and alternate pathway. How the various complexes are involved in the complement system. We'll discuss them. There is a question based on that, and we have to understand the various intermediates. It is the smallest immunoglobulin. So how you can learn is because it is the smallest, so it can pass through placenta, so mother to the fetus. It is also known as warm immunoglobulin, and it is a predominant immunoglobulin in the gingival clavicular fluid. So there can be a question that which is the most prevalent in GCF, that is gingival clavicular fluid. It's the IgG. Next is the IgM. It is the earliest immunoglobulin synthesized by the fetus in response to immune infection, right? So it is the earliest, the earliest immunoglobulin. Its half-life is only 5 days. Okay. It is only 5 to 8% of the immunoglobulins. It is the oldest immunoglobulin class. Now, the presence of IgM in the fetus or the newborn indicates intrauterine infection and is useful in the diagnosis of congenital infections such as syphilis, rubella, and HIV. So IgM in the fetus, it's like because it is the earliest immunoglobulin. So if there is any infection, so the earliest immunoglobulin which a fetus can make is the IgM. IgM antibodies are short-lived. So usually it's a fact, whatever comes very early goes very early. So learn like this, okay? So whatever comes in early goes early. So IgM antibodies are short-lived and disappear earlier, right? Hence their demonstration in the serum indicates recent infection because they come early and go early. Both IgG and IgM class of immunoglobulins activates a classical pathway of complement fixation. It is also known as cold immunoglobulin. Both IgG and IgM are involved in type 2 or cytotoxic type of hypersensitivity reactions. So the hypersensitivity reactions we will be learning, type 1, type 2, type 3, and type 4. We'll learn them. Okay. Next is the IgA. It is the second most abundant class. I told you GAMDE. So it occurs in two forms, serum IgA and secretory IgA. Secretory IgA is synthesized from the mucosal or the granular epithelium and protects IgA from the proteolysis. It is a predominant immunoglobulin in the saliva, which is one of our questions, that in the saliva, which is a predominant immunoglobulin. So the answer is IgA. Immunoglobulin present in exocrine secretions. Caries vaccine is prepared based on the action of IgA in the oral cavity. So this can also be a question in the exam, that the caries vaccine is related to which immunoglobulin. So it will be again IgA. Then it activates the alternate pathway of the complement system. This can also be a basic question. And both Ig and IgG are secreted in the milk. Now let's go to the IgE. It has a unique property of heat lability. So it is heat labile, that is inactivated at 56 degrees Celsius in 1 hour. So it breaks with the heat. It has affinity for the mast cells of the same species, which is called as homocytotropism. So it mediates, so basically whenever we talk about mast cells, we talk about inflammation. It mediates the Prasunitzky-Kursner reaction, a method to detect atopic antibody. It is responsible for anaphylactic type of hypersensitivity reactions. For example, contact dermatitis. Chiefly produced in the lining of respiratory and intestinal tracts is the IgE. It is believed to have a special role in parasitic infections as well. So there can be a question, which immunoglobulin is related to parasitic infestation? It is again IgE. So allergy. Now, last but not the least, IgD. It is structurally resemble IgG. IgD and IgM are serves as recognition receptors for the antigens and activates the B lymphocytes for antibody production or suppression. We'll also read about the various like B lymphocytes and T lymphocytes, cell-mediated immunity, humoral-mediated immunity. Humoral means antibody-mediated immunity, right? In the cell-mediated immunity, we have the cytotoxic T cells and the helper T cells. And the B cells are involved with the humoral immunity whenever antibodies are formed. So B cells converts into plasma cells, which gives rise to antibodies. Now, next, we go to question number 6. So let's, end the discussion at question number 5. In the next session, part 2, we'll be discussing the questions from question number 6 and onwards, and we'll be discussing all the questions in detail this way. So we'll be discussing all the options. Thank you and have a wonderful day.